thank you for that question. I think so. By definition, congenital heart disease is structural heart disease that is present at birth. So if you want to screen properly, you should consider starting screening even before birth. So for the especially for the more severe forms of structural congenital heart disease, and then I'm thinking of single ventricle situations. Fetal ultrasound can definitely help us to screen for those cases in even in a prenatal setting, and even more mild forms of congenital heart disease can be detected if properly done. So I think fetal ultrasound has become well, one of the main stage screening methods for congenital heart disease. And then, of course, you need to have proper strategies for dealing with what you find, and issues of interruption of pregnancy need to be well discussed and need to be well communicated to the patients, taking into account cultural and other backgrounds that you need to consider. So that is what you need for screening from the beginning. Other than that, later in life, so once in people who are born with congenital heart disease, it is very important to know that most of these patients, even the one with mild lesions, will require lifelong follow-up. Meaning that they should be made aware of the fact that they need lifelong treatment and follow-up, and that they are not lost to follow-up, because that is, in many regions, is an important issue, that in many patients will have follow-up during the pediatric age. But once they grow adult, there's a risk that once they need to move to the adult facilities, that they get lost, and that care is not continued, and that is a risky phase, and we really need to have proper transition programs to avoid lost to follow-up, because people that present in later stages will often present with severe sequelae that may have been avoided if they had earlier checkups. So that is, I mean, in the context of screening, I think fetal ultrasound, and then of course, I mean, every physician seeing a patient who has obvious signs of heart failure or of cyanosis, or has murmurs that cannot be explained, need to be referred to proper physicians for further screening. So that's for the screening and prevention. I think these are the most important issues. So fetal ultrasound and proper transition programs, so that patients cannot escape from follow-up. Well, as I mentioned, I think in screening, it's a matter of awareness, awareness of the general population, obviously, but especially awareness in the medical community, so of healthcare providers. I think fetal ultrasound, I don't know how how this is structured in the Chinese regions. In Western European region, we have, like, it's become one of the basic exams during pregnancy. So all women will undergo a fetal ultrasound, looking specifically at the heart and at the structures of the heart. So that is something that needs to be implemented in follow-up of pregnancy. With regards to screening of then children, there's red flags that need to be known by physicians who treat babies and children. So again, murmurs, cyanosis, and signs of heart failure those cases need referral. And then the tricky phase of transitioning from pediatric to adult care needs to be well managed and needs to be well prepared. It's often in this stage of moving from pediatric services to adult services that patients get lost. And in some countries, in some regions, I know that there's active screening programs in the adult population to recover patients who have been lost to follow up. An even better strategy is to prevent this and to have programs that will be active from the pediatric phase on. And if you don't have this, if you don't have these transition programs, then I think active screening programs, again, with red flags for adult healthcare physicians, so cardiologists and others, pulmonologists, whoever encounters patients that have unexplained fatigue or signs of heart failure should get proper evaluations. And yeah, I mean, but again, this can be avoided if proper transition can take place. So in my country, in Belgium, the number of patients that are lost to follow up, or the subset of patients that are lost is very low. So we have, I mean, Belgium is a very small country when compared to China. It's microscopic, so to say. So we don't have these long distances that patients need to travel to get to a center with proper care. So I fully realize that this is a big advantage that we have. So we have very few cases that are lost to follow up. Patients will usually transition well from pediatric to adult care facilities. The problems that we are facing are mainly related to the aging of the patient cohort. So patients are getting older, are also encountering acquired heart disease and other medical problems that need to be dealt with. So we see increasing numbers of patients with corrected or repaired congenital heart disease who have arrhythmias is a very important problem. So we need so people from the EP lab, people dealing with arrhythmia that are aware of congenital heart disease, that know what they can and what they can't do and what needs to be taken into account. A patient with congenital heart disease, you will not always directly move to interventions or to device placement. You also have to take the hemodynamic aspects into account. So you need properly trained electrophysiologists who can deal with these patients. We have increasing numbers of patients presenting with a heart failure. So with more people growing older, we have large cohorts of patients that get into a situation of heart failure. And we all know that conventional, so optimal medical treatment of heart failure, that is where we have guidelines for acquired heart disease, do not always apply to patients with congenital heart disease. And that is a big problem. So patients with congenital heart disease have very often been excluded from large trials. So there's very few data. There's only small, often single center studies. So we really need to make sure that we have collaborative efforts where we can address this more properly. And then in stages of end-stage heart failure, there's the issue of transplantation. So heart transplantation is the only way out in some of our patients, but we all know that and I think this is a global issue, that there's a very big shortage of donors, and very often transplant centers will they will be a little bit afraid, or they will be inclined to not accept patients with congenital heart disease, because yeah, they have often quite or more complex anatomies. And also it is known that on the long term, the outcome of heart transplantation in these patients is much better than in the general transplant population. But there's a steep decline in the early phases, and this is related to technical issues. And this is why some people will be reluctant to accept patients with congenital heart disease for transplant, which is a pity, because these are different, very often young patients who should get that type of care. And well, without going into the details, there's many patients who will not only have a failing heart, but will have a failing liver or failing lungs in association with their heart failure. And then you need combined organ transplantation, which obviously makes the procedures much more complex. But that is a growing cohort of patients that we see moving towards end-stage heart failure, and there we need proper programs with transplantation. But not only with transplantation, I think it is very important that we have proper advanced care planning programs, and that we offer that to all our patients, so that we can give them a proper, well, a proper view on the future, and that they have, well, that they have a realistic idea of what is to come. And this takes time. Having advanced care planning talks with patients takes a lot of time, and this is often something that is not well received by our hospital directions, who want us to see a lot of patients on a short time course, because I mean, there's financial issues related to that, but we really need to, yeah, I mean, talk with our patients, and if it needs time, then we need to take that time. And it would be nice if the directors would be made aware of these issues, and would acknowledge that we need yeah, not only time but also personnel to tackle those difficult discussions. Yeah, well, so as in general cardiology interventions, so interventional procedures are gaining importance, and this is also the case in congenital heart disease. There's well, there's a lot more evidence for example, for stenting in the setting of aortic coarctation, which is now the mainstay or the main treatment modality in adult patients presenting with coarctation. So there's a lot of progress made there with the covered stents that are now routinely used and give very good long-term results. So that's one example. There's obviously pulmonary valve replacement, where percutaneous techniques have gained importance, and where we can move to valve replacement in an earlier stage than what we would do if we needed surgery. And also there's good progress made for treating native pulmonary outflow tracts with percutaneous techniques. So this is another example, and other examples include ASD closure, where now recent studies have also indicated that even in the setting of a sinus venosus ASD, where well, this used to be a surgical indication where percutaneous treatment was not feasible, but also there's been some evolution, and now there's techniques to also treat these patients via percutaneous way. So this is another example. And then obviously the aortic valve replacement, the TAVR techniques have evolved and are gaining importance also in the younger population. So there's good results in patients with bicuspid aortic valves, for example. And I'm sure that in the future these techniques will gain importance over the surgical procedures. And of course, there's like the clipping of tricuspid valves, which tricuspid valve disease is common in congenital heart disease. And I think that these techniques are so the development there is moving very fast and is giving us some promising prospects for the future. So I already mentioned a lot of the points that are important for the future, but I just want to maybe summarize some of them again. I think for the future, as I mentioned, transition programs need to be formalized and need to be installed in every center dealing with patients with congenital heart disease. And along with that, the modalities for advanced care planning in these patients need to be properly installed. So there need to be strict strategies for advanced care planning discussions with the patients, and this needs to be well organized, not only with physicians, but also with psychologists and with social care workers who can help dealing with the problems that these patients face. Regarding heart failure, there is a clear need for collaborative efforts to study the effect of heart failure treatment in patients with congenital heart disease. I think we need a global effort there. So we need really big, large international trials where many patients can be included and where the effect of these treatments can be properly tested. I also mentioned the aspect of aging. So aging and all disease issues that come with aging, acquired heart disease, but not only heart disease, need to be addressed, and we need to be aware of the growing aging congenital heart disease population that will, even more than the general population, have problems with arrhythmia, with heart failure, and we need to have strategies for proper management of this growing group. And I think that in the future, the integration of data coming out of genetic studies, I think genetics are also gaining much importance in the setting of congenital heart disease. The genetic background, which is often not monogenetic but often oligogenetic, of these diseases is better known now than a few years ago, and will get better known in the future years. And I think that from there, knowing the genetic background, we will be able to develop more targeted treatment options. And I think the integration of what comes out of larger scale genetic studies and the genetic knowledge with techniques, including artificial intelligence, looking at imaging data, will definitely help us in the future. And this may sound a bit science fiction like at the moment, but I do think that we are already entering that stage of integrating large scale genetic and imaging and other data that can be acquired through artificial intelligence that will help to better diagnose and treat our patients. And I absolutely I am a very strong believer in personalized medicine in this setting. I think, well, there's no two congenital heart disease patients that can be put into one basket. I think every patient needs an individualized approach, and with increasing knowledge about the background and the current status, I think will move things forward and will lead to better treatment of our patients.